Hello, good afternoon. For those of you who don't know me, I do know some faces in the audience. I'm Andrew Tarry. I'm a commissioning manager at the moment in NHS Hertfordshire. Watch this space. There's a nice snappy title beginning to this, and I can't claim any credit for that. QMAS is dead. Ray. Long live CQRS. What the hell's that? Another set of acronyms, I'm afraid. We do so love acronyms, don't we? So I'm here to tell you a little bit about CQRS, and really the position that I'm doing that from is I sit on the end user working group nationally and have done for the last year or so. So I should know something about it, hopefully. So CQRS, before we really start, just to confirm what it is that it stands for, even though it'd be one of these acronyms that we forget what it means, like QMAS. I can never remember what QMAS stands for, but we know what it does. And I have to look it up, because I always keep getting it wrong. Calculating Quality Reporting Service. And that sort of describes what it is going to do. The rider I would add here to begin with, and to cover myself here, I'm using a national presentation. They're very keen that there's a consistent message that's used nationally. So forgive me if I've no idea what it says on there, because I haven't written it. But I should know something about the whole thing. So, if we can go on to the next page, if you wouldn't mind. Bit of an introduction, and probably some of this introduction is rather unnecessary. You might be slightly aware of the Health and Social Care Act and some of the changes that have impacted on us all, but it's there as an outline of the introduction. And just a bit of context, QMAS, as you probably know, has been around for, I think, almost 10 years. I think it's BT who provide it. The contract for QMAS was coming to an end as of the end of this year anyway, so it was up for recontracting. And the Department of Health wished to commission the project to replace it and actually expand the scope of what QMAS did previously. And that's why I'd hasten to add on this, CQRS isn't just a replacement for QMAS, it's so much more. As we'll go on and find out about. So it is a generic calculating tool. Again, a little bit of background on this. The company that's actually developing this for the Department of Health is a company called Vangent, who I'm sure you've never heard of. I haven't. They're an American company, part of General Dynamics as a larger group. As some sort of reassurance, they run and develop the largest medical database, claim and payment systems in the States. So this is an area that they have a lot of expertise in and are very honed in terms of doing that. And essentially the tool that CQRS is becoming is based on what they've done in the States for some time. So this isn't new technology that we're acting as guinea pigs on. It's very much technology that has been used in the US. And again, a bit of reassurance that a lot of the development work that's been ongoing is about making something that's worked in the US, making it very specific to us in the UK and for the NHS. So you shouldn't see lots of Americanisms and things like that in it. And the new service will go live for the 2013-14 financial year. Hey. So yes, it's due to go live for the 1st of April. So why do we need a new service? Well, one, QMAS isn't going to be there anymore, and the contract's ceased. So we clearly needed a new tool for it. This is quite a key point here. QMAS makes accurate payments for QOF, we hope, but major elements of the system are sometimes not available to users for a large part of the year. As you know, I mean, when do we get QMAS online? September, October, if you're lucky. And that's part of the problem, I believe, in terms of how QMAS was set up initially. It's very much hard-coded. They've got to go and rewrite so many big sections of it every time something changes in QOF. And we think quite a lot's going to be changing in Croft next year, don't we? So that would make it even more prone to delay. So the whole point of this system is it's very flexible. It can be available a lot quicker and therefore give you the transparency and the awareness of how you're achieving. This element I alluded to a little bit earlier on, in that this isn't just about supporting QOF achievement, it's about supporting any other quality-related payments. DESIs being childhood IMSS, and indeed, in due course, LESIs. Essentially, anything that can be drawn in a generic manner out of your clinical systems for claim purposes can be managed on CQRS. And that last point is probably quite an important one in terms of what we're all going through as well. It is very flexible. Clearly, when they started to spec this out in the first instance, they didn't know the extent of the changes and quite what was going to be happening. But the fact that it's flexible has meant what we've been able to keep up with those requirements. So, CQRS, as you can read there, will record, monitor and report and calculate achievement and payments on what they call quality services, and listed there are some of those elements there. And it mentions elements that go beyond the scope of the GP contract, so the commissioning outcomes framework in due course, elements that the CCGs are going to be targeted on. Again, it will be able to support that. It says something there about the commissioning board will need to decide on the business model of the service provided to support CCGs on that. Commissioning board, as you know, have probably got quite a lot the work cut out to decide lots of those things, so we await to see quite how they will do that. And a key point here at the bottom, it's taking data both from Health and Social Care Information Centre and probably most importantly for your purposes, from your systems via the GPES, another acronym, General Practice Extraction Service. And I think the next slide goes and tells us a bit more about it. I don't profess to know a great deal about this, but I believe there is more information coming out about this. And again, there is an end user working group that's working on that. But essentially, GPES is about extracting data from your clinical systems, so much as is done at present for QMAS, for QOF achievement. And GPES is about aiming to centralise that data query and come up with a standard approach. GPES doesn't calculate the payments. It merely brings that information into CQRS, which is why the two go hand in hand. And GPES sends the anonymous data into CQRS for the achievement and payment calculation. There is a link there that there is more information starting to come out now through the information centre. So I would prompt you to go and have a look at that link to keep up to date with what's going on there. We then go on to talk about some of the key terms that are within CQRS. There's just a couple of concepts that you probably need to be aware of as you go forward. So organisations may fulfil different roles within CQRS, and it gives the example of CCGs can either be commissioning organisations, i.e. for locally enhanced services, or service providers for elements from the commissioning board. And it comes, this concept is basically called a participation agreement, which in a sense is a bit of an electronic handshake, i.e. here's a service offered to you as a practice. Do you wish to participate in that? Yes, you do. That's the participation agreement. It doesn't replace necessarily a formal sign-up to whatever enhanced service, etc. that is, but it's the electronic process of saying, yes, I'm participating in this, and therefore my data is to be released for this purpose. That's not a hugely interesting slide, I don't think, that one. You could argue most of them aren't, but that one particularly I don't think is. A commissioning organisation can see all the quality services it's offered. Whoopie-doo. You would hope it would be able to. And you can see all those that you are participating in. Yay! Next one, please. Another term they use in here is quality service, which the term they're using to describe a service commissioned by the NHS. So QOF will be a quality service, the various individual DESs. So it's just getting a bit used to the terminology that they are using for that purpose. And any service that's supported can be supported providing it follows the given data collection and calculation principles, i.e. it's not patient identifiable, and it's got the calculations that are similar to the calculations that are in CQRS at the moment, this is where in due course CCGs can go on and add LESs into CQRS because they can operate on that same generic basis. So how do we support quality services? Once QOF has been negotiated and determined, and at what month in the year we'll find that out, who knows, it will be made available on CQRS. And at that stage, the commissioning board, the local area, will offer that quality service to you as practices, as service providers. And then you can decide whether you wish to reject or participate. And at any point, you can view details of QOF. And again, this is quite an important point here, such as the indicators and their thresholds and points on CQRS. From certainly what I've seen of it, and as against one of my big bugbears on QMAS, is you get a set of figures on there. You're not necessarily sure how it's been determined. It's not entirely clear if you wanted to understand more about that indicator. CQRS generally will be a lot easier to use, will be intuitive, and it will give you help screens so you can get a lot more detail on how those indicators are calculated. For commissioning organisations, which you're probably not so interested in, CCGs, as I mentioned, say on LESs, will be able to offer you as service providers the opportunity to participate in services. And CCGs can then use CQRS as a monitoring service on LESs. It says CCGs will spend less time on approving quality services delivered against the participation agreement. And again, I think we'll come on to this in a little bit. The whole point of this, it's supposed to streamline the process. Rather than there being a manual process of you, say, having to report out of clinical systems, put it on a form, email it to someone, hope it gets there, hope they deal with it. The whole point is it's done in a smooth and streamlined way, which I think is that first point there. The time saving effectively, and the transparency of your achievement and where you are, which I know sometimes is lacking in terms of giving you that understanding. Again, back onto this point about flexibility, as things change, CQRS, because it is this generic tool, can very much be developed on the hoof and in a very quick timescale to make sure it's fit for purpose and can offer you that functionality. And indeed, again, as I mentioned earlier on, CCGs can end up taking different approaches across the country and doing different things on CQRS as long as it meets those standard requirements. So I don't think genuinely we're expecting a lot of that to be happening in the beginning of year one, because there's quite a bit happening, and this will be available as of 1st of April. So it will be those national obviously QOF very much in the first instance, and the DESs. And in due course, there is that scope there for CCGs. I've probably said some of this already, but it is about the visibility of showing, clearly showing this transparency issue. I think that is a key issue, and the fact that it's kept up to date. So we haven't got this big 5-6 month delay at the beginning of the year waiting for everything to come on board. This last point I do want to emphasise quite a lot here. There has been a heavy involvement from end users as against some of these systems and/or initiatives you see coming from above where you think, has anyone who's ever going to be involved in doing this ever seen this before we get it? Yes, they have for this. So from the beginning of the process, even in the initial specification and the selection of the providers, there has been a core end-user working group involved. And again, to reassure you, that includes quite a number of practice managers from across the country who have been very heavily involved in it. I'm a latecomer. I've only joined in the last year. When they selected the supplier, they then expanded the group to get more involvement. And I know that this project has been praised in terms of the scrutiny it's been through in terms of having this level of end-user involvement. So I think there's been a recognition from Connecting for Health that it hasn't always been something that's been done with that true engagement with end users. So they've been very keen to ensure this time it's done in that manner. There's going to be lots of training of lots of types. Again, I'm hoping it will be very, it certainly is from what I've seen, being very easy to use and very intuitive. But there are going to be a range of methods whereby you'll be able to get up to speed on it. Again, there's a list of some of those resources that are there, and they'll be doing webinars as well, which I think I think what they're trying to do, rather than release too much of that training too early, there's certainly been a debate about not giving that too early, i.e. now, when you won't see the system for 4 months and you won't be able to use it. Better to do that very close to when it's being launched, accepting that actually and a little bit of reassurance, QMAS doesn't get turned off on the 31st of March. We've got it until some point in the end of July, so we will be signing off 1213 achievement within QMAS before it's turned off. And then the data, I think, from at least 2008-9 is then going to be exported into CQRS. So you will have that historical view as well. And I think there's a very last slide. So just a bit of a call to action. They're keeping updated on Connecting for Health website, and there is. I would urge you to go and sign up. So if you haven't got enough meaningless emails already, there's some more to get. But hopefully these aren't too meaningless. Hopefully they're quite. From what I've seen, the communications are quite short and to the point, and telling you what's actually going on. But I think they are going to try and use the email addresses we've got within QMAS, but accepting that they're not necessarily all up to date. So if you want to proactively know what's going on, I would urge you to sign up, and you can get those bulletins to let you know what's coming. You can register for the training events or the webinars that are coming up. And very much that training will be, the first module being about an overall introduction to CQRS, and that being done at some point in March, with some more detailed training coming through May, which is actually getting into when you've then got the system, it's then actually got the details of, right, how do I use this thing? So hopefully that enlightens you a little bit to what I would hope to reassure you that it's, as I say, from what I've seen of it, it's been a very well thought out system based on tried and tested technology. God, it's got to be better than QMAS, hasn't it, please? And it is considerably better. And I do think there is that time-saving element that we're not all running around trying to manage a claims process that actually you've already got documented in your clinical systems. So I think there's big advantages for us all in there.
Thank you very much. Any questions? Any questions?
Traditionally, we've had changes in business rules and read codes that have come into the practices in December. This obviously perhaps isn't going to happen with the new system. Will our clinical system suppliers be up to speed so it happens within year, at the beginning of the year? And if not, what's the appeals procedure against CQRS?
I think we did debate this as part of the end user group, and it's one of those ones that it's not quite in the scope of the project, unfortunately, in that I suppose that CQRS is being delivered as a tool to work within those business rules that are provided. I think through GPES, pressure is being put on clinical system suppliers to react quickly, whereas previously maybe there hasn't been so much pressure because simply QMAS hasn't been available for so long. Now it will be very visible and you will know. So I believe pressure is being put on, but that I can't provide you with any sort of guarantee of what, and I can totally appreciate that's a frustration with those changes coming on a lot later in the year.
Any more questions? Yep.
From what you've said and looking at your slides in detail, it appears that the system's going to have the capability to report on any read code. So is it going to be used to look at our referral management in the future?
I haven't heard any discussion of that. I can't even remember what's in the commissioning outcomes framework.
But it says here that it will have the capability to report against CCG outcome indicators. Certainly in our CCG locally, most of those outcomes that we're talking about are around referral management. So that would imply that that will be a use of the system.
I'd love to be able to give you a full response on that. I honestly don't know. I think the key priority of it's a achievement and payment service. So that if this is elements that you are being paid for, then that would seem logical and therefore possible that may be the case. To some extent, I suppose the development of the system has had to go on a little bit in isolation of what services are going to be provided, because actually, as you probably know, there's a lot of uncertainty as to what they are. So this has been about developing this as a generic tool that can flex to those things. So I wouldn't like to say, yes, it's going to include them, or no, it's not, but it's possible.
Okay, thanks very much. Just one more question.
Just wondered whether it's going to allow you to do any sort of peer review.
In what sense, peer review?
Well, at the moment we get things like our preference and everything is historic.
Mm.
It's quite nice to be able to say, right, you know, within our locality, this is my performance against other people, this is my preference, that might be an area I want to look at.
That's a good question. I can't remember in terms of the reporting. The reporting on this is certainly allowing a lot more flexibility, which wouldn't be hard as against what we had previously. I'm not sure. I can take that one back and pose the question. I mean, clearly it's going to be providing that from a commissioning point of view, but I appreciate you will be interested in that from a comparing with your peers at a practice level. So I don't know. I'll take that question back and find out.
Okay, thanks very much then. Thank you very much, Andrew.